Good evening, ladies and gentlemen. Thank you very much for joining with us today afternoon for this webinar. I'm Dr. Chatura Jayapudi, the Senior Medical Advisor for GSK Sri Lanka. So it's my pleasure to welcome all of you to today's webinar. My special welcome to our speaker today, Dr. Maheshika Vijayawardena. You are warmly welcome, sir. And just before we begin, I would like to give you some couple of housekeeping instructions. During the webinar, if you have any questions, please use your Q&A box to forward your questions to us. So we will be taking questions at the end of the session. So without much ado, let us start the webinar. So topic for discussion today is the importance of optional vaccines. So now it's my duty and pleasure to introduce our speaker today. Dr. Maheshika Vijayawardena, MBBS, DCH, MD Pediatrics, MRC PCH, UK. So he obtained his MBBS from University of Colombo in 2003 with a second class, and DCH in 2007 from PGIM Colombo, and MD Pediatrics in 2011 from the Postgraduate Institute of Medicine, University of Colombo, and MRC PCH in 2014 from Royal College of Pediatrics and Childhood in London. He went on with his foreign training in pediatrics for 2 years at Darlington Memorial Hospital in UK. With his return, he held a couple of positions as acting consultant pediatrician at Ashraf Memorial Hospital, Kalmune from 2015 to 16, and DGH Ampara in 2016, and as consultant pediatrician at DGH Ampara 2017 to 2020. Currently, he is serving as a consultant pediatrician at Base Hospital, Pathupitivela. Now it's my pleasure to invite Dr. Maheshika Vijayawardena to carry on with the webinar today. Over to you, sir.
Let me share my slides. Mel, can you see the slides?
Yes.
Yes, sir. Yes.
Right. Okay. I can start now then, no? Good evening, everyone. And thank you, Chatra, for that kind introduction. So as you know, today I'm going to talk about the importance of optional vaccines. During my lecture, I will be mainly concentrating on three disease conditions, three vaccine preventable disease conditions, namely pneumococcal disease, Varicella Zoster infection, and rotavirus infection, and their respective vaccinations. I'm going to talk, but I'm not going to talk in detail about any of the vaccines during my lecture today. And even though these vaccines, pneumococcal vaccine, varicella vaccine, and rotavirus vaccine, they are optional in Sri Lanka, but most of them, like pneumococcal vaccine and rotavirus vaccine, they are in the routine schedule in most Western countries. And varicella vaccine is also there in national schedule in some countries. So before I start my lecture, I would like to give some information facts about our national immunization program. So it is one of the strongest performers in the region, and it is among the best in the world. So our vaccine coverage, according to WHO data, exceeds 99%. And we have started our vaccination program back in 1886 with smallpox vaccine, and later on BCG was introduced in 1949, and DPT and OPV vaccines were introduced in 1961 and 1962 respectively, and human papilloma virus was the last to be introduced. That was introduced in human papilloma virus vaccine. It was introduced in July 2017. And as a result of this successful program, actually we have got rid of, basically we have eradicated polio, and last polio proven case of polio was seen in 1993 in Sri Lanka. And because of the successful program, nowadays we don't see conditions like measles and epiglottitis anymore. Actually in the future, at present these three vaccines are optional in Sri Lanka, but pneumococcal vaccine will be introduced to the national schedule soon, and later on hopefully rotavirus will be also included in the future. Right. So, as Chatura pointed out, you can type your questions. If you have any questions, you can type them in the Q&A box. And at the end of the lecture, I'll try to answer some of those questions. And I want you to do some other thing also. That is, you have to type in that Q&A box something you have learned today from my lecture, right? Don't type it now. So at the end of the lecture, you can type something you have learned, you think is important from the lecture today. Right. Hope you all can hear me clearly.
Yes, loud and clear.
Right, thank you. And so regarding pneumonia in children, pneumonia is more common in younger age group, less than 5-year age group. And there are risk factors like overcrowding and having siblings who are attending schools, daycares, and nurseries, and children who are having underlying medical disorders. It may be conditions like structural lung pathologies, or like chronic lung diseases like asthma, and it may be immune deficiencies in the like it can be primary immune deficiency, congenital ones, or it may be acquired due to use of steroids and or chemotherapy. And agents commonly responsible for this pneumonia vary according to the age of the child and the setting, that is whether it is acquired in community setting or in the hospital. Right. Less than 5-year age group, actually viruses are more common, like viruses will cause pneumonia commonly. And however, the bacteria like Streptococcus pneumoniae, Staph aureus, and Strep pathogenesis are important bacterial causes. And old age group, that is more than 5 years age group, Strep pneumoniae, Mycoplasma pneumoniae, and chlamydia pneumoniae are important bacterial pathogens. So community-associated MRSA is increasingly important pathogen in children of all ages throughout the world. And it is particularly a cause for necrotizing pneumonia. And Strep pneumonia is also a cause for necrotizing pneumonia. So this necrotizing pneumonia is an aggressive form of pneumonia where there is consolidation and effusions and cavitation of lung with the destruction of lung parenchyma. So hospital-acquired pneumonia is usually caused by gram-negative bacilli or Staph aureus. So regarding pneumococcal pneumonia in children, so Strep pneumonia is the most common cause of typical bacterial pneumonia in children, and it accounts for more than 1 million deaths annually around the world. And clinical manifestations of streptococcal pneumonia infection include fever, non-productive cough, and features of respiratory distress, and decreased breath sounds, that is features of consolidation. And complications are quite common, seen in up to 40 to 70% of patients. And in that picture over there, you can see this gram-positive diplococcal strep pneumonia. Actually, strep pneumonia can cause a spectrum of disease. Out of those, most common conditions are otitis media, sinusitis, pneumonia, and sepsis. And also bacteremia can lead to meningitis, osteomyelitis, suppurative arthritis, endocarditis, and even brain abscess. It can also cause primary peritonitis, especially in children with nephrotic syndrome. And local complications include pleural effusions, empyema, lung abscess, necrotizing pneumonia, pneumatoceles, pneumothorax, etc. Rarely, it can be a cause for HUS, or hemolytic uremic syndrome, or disseminated intravascular coagulation, or epidemic conjunctivitis. So important point is, it's an important cause of secondary bacterial infection in influenza, right? Following influenza infection in the chest, this can cause secondary bacterial infection. So similarly, during the current COVID-19 pandemic, also it can cause secondary bacterial infection and lead to morbidity and mortality. History examination and radiographic findings usually establish the diagnosis of strep pneumonia, and specific diagnosis is by culture of the organism from the blood or pleural fluid. And most of this community-acquired pneumonia are treated empirically with empiric antibiotics. So usually the treatment includes beta-lactam antibiotic like penicillin or cephalosporin. So having said that, some studies have shown increased resistance of these organisms in Sri Lanka to penicillin. So when the ABST pattern is known, we can change the antibiotics accordingly. And usual first-line drug used include IV drugs are penicillin or ampicillin, and oral would be amoxicillin. And we use these drugs if the penicillin minimal inhibitory concentrations are less than 2. So that means the concentration of this penicillin needed to destroy half of the 50% of the colony. So less than 2 means these are less virulent serotypes. And alternative IV agents include cefotaxime, ceftriaxone, clindamycin, vancomycin, or levofloxacin. And oral antibiotics are given there. And if the organisms are more virulent, like that is penicillin minimal inhibitory concentrations are more than 2, then you have to go for antibiotics like IV antibiotics like ceftriaxone or cefotaxime. And oral, if you are using oral antibiotics, it would be levofloxacin or linezolid. And other alternatives are mentioned there. Typically, we have to continue the treatment for 5 to 7 days in an uncomplicated disease, or until the patient is afebrile for 5 days in a severe cases. And most of the healthy children who have a sound immune system will recover without any problem, without complications. Case fatality rate is like higher in young age group, less than 2 year age group is 4, which is double that compared to 2 to 17-year age group. So microbiology and pathogenesis of Strep pneumoniae. So Streptococcus pneumoniae occupies an important position in the history of microbiology. So this organism was first identified in way back in 1881, and people have identified that it is the causative organism for lobar pneumonia later in the same decade. And central role of antibody in the host defense against extracellular organisms was first described for this pneumococcus. And discovery of DNA as the material for genetic exchange was also made using this organism. So despite the availability of vaccines, so Streptococcus pneumoniae continue to cause invasive disease in children as well as in older adults. It principally, like as I mentioned earlier, causes otitis media, pneumonia, bacteremia, and meningitis. Another significant challenge all around the world is the emergence of multiple antibiotic resistant pneumococci. So it ranges from 15 to 30%. So Strep pneumoniae is a gram-positive alpha-hemolytic bacterium. It is a fastidious, that means it requires like a bit of a fuzzy organism requiring some conditions to grow, like it needs 5% carbon dioxide and also blood growing on eggs. And feature Strep pneumoniae is the tremendous diversity among different strains. This diversity is localized to the regions of the chromosome that alter the virulence of the strain, and this virulence is partly related to the size of the capsule. Around 100 different pneumococcal serotypes have been identified, and but the important thing is around 20 of them cause like 80% of the disease burden. So the capsular polysaccharide is the major antiphagocytic surface element of pneumococci and the major protective antigen. And this pneumococci will adhere to the epithelial cells in the nasopharynx, and that adherence itself will not cause symptomatic infection. And some of these organisms have villi to facilitate this adherence. So who are the children who are at risk of invasive pneumococcal infection? So children with sickle cell disease, for example, as you know, these children with sickle cell disease, they will develop splenic infarcts, and with age they will undergo what is called autosplenectomy. So they are at increased risk of invasive pneumococcal infection, and also infections by other encapsulated organisms. And also children with congenital or acquired asplenia or splenic dysfunction, and children with cochlear implant, because it's an invasive procedure. It involves inserting probes into the inner ear. And children with malignancies are also at risk, like children with leukemia, lymphoma, they will be on chemotherapy as well. And presumed risk is seen in conditions mentioned there. So moving on to pneumococcal meningitis in children, and Streptococcus pneumoniae is the most common cause of bacterial meningitis in children. And as mentioned before, certain children are at increased risk. And clinical manifestations, so what are the clinical manifestations? Include like they are seen in other bacterial meningitis as well, and they include fever, neck stiffness, irritability, confusion, or altered mental status, headache, photophobia, nausea, and vomiting. So what is the situation with regard to pneumococcal meningitis in Sri Lanka? So one study has shown the incidence to be around 8 cases per 100,000 children aged less than 5 years. They have some common serotypes, and out of these, 60% are covered by 7-valent pneumococcal vaccine, and this coverage was increased to 65% with the 10-valent vaccine. So this study has also pointed out an important thing, that is more than 90% of the isolates were penicillin resistant, and the resistance for third generation cephalosporins were also found to be high in that study. So diagnosis pneumococcal meningitis requires detection of this organism in the CSF culture, gram stain, or by rapid diagnostic tests, like that is antigen tests. And if there's a positive blood culture for strep pneumoniae, and if the CSF is also positive with pleocytosis, you can also diagnose pneumococcal meningitis. So this is how you see Streptococcus pneumoniae in the CSF as gram-positive diplococci. So if you're suspecting bacterial meningitis in any child, you have to start them on antibiotics, proper antibiotics with adequate dose, and you have to also manage associated complications. The use of DEXA in pneumococcal meningitis is controversial. So it is mainly indicated for Hib meningitis, Haemophilus influenza type B meningitis. But so it can also be used in community acquired meningitis in the age of more than 6 weeks or less than 5 years, or suspected bacterial meningitis in children with sickle cell disease or hypersplenism. So the practice depends on the clinician, like the practice can vary from place to place. But if you start DEXA, you have to start it before the antibiotic treatment, or at least with the first dose of antibiotic. And it is known to cause reduce the neurological complications like hearing problems. Empiric therapy for bacterial meningitis in infants and children who are more than 1 month include coverage of strep pneumoniae, and one commonly used empiric regimen is vancomycin plus ceftriaxone or cefotaxime. And later on, you can adjust the antibiotics or change the antibiotics according to the antibiotic sensitivity pattern. And you can monitor the response to treatment clinically. And if child is not improving, you might to repeat the CSF examination or lumbar puncture. Some instances you have to do the repeat lumbar puncture, especially if the initial lumbar puncture was strongly positive. You have to do, and you have to get guided by the clinical picture and the other investigation findings. So mortality rate for pneumococcal meningitis is approximately 8 to 10%, and up to half of the survivors will have long sequelae. And all children we treat for meningitis should undergo hearing evaluation, and hearing loss is seen up to 20 to 30% of children who had pneumococcal meningitis. And also you have to follow them up for neurological deficits, for developmental delay, cognitive impairment, and so on. So regarding pneumococcal vaccination, there are two types of vaccines available to prevent pneumococcal disease. One is pneumococcal conjugate vaccine, and other one is pneumococcal polysaccharide vaccine. So children less than 5 years, especially children who are less than 2 years, are at increased risk of invasive pneumococcal disease, and WHO recommends PCV immunization for all infants, and routine immunization with PCV is effective in preventing invasive pneumococcal disease in vaccinated children, and it also provides herd immunity to the non-vaccinated children and adults. So meta-analysis of randomized trials showed that the efficacy of PCV in preventing invasive pneumococcal disease was 80%. It also prevents pneumonia and otitis media. This is called conjugate vaccine, promote T-cell immunity and also protect against pneumococcal colonization. So the risk of invasive pneumococcal disease increase in children who are older than 2 years, children who are immunocompromised or have CSF leak, cochlear implant, and certain chronic diseases like sickle cell disease. So pneumococcal polysaccharide vaccine, that is 23-valent vaccine, is recommended for more than 2-year age group. And it covers pneumococcal polysaccharide vaccine covers 23 strains, serotypes, but it is effective only in more than 2 years age group. Even though the child is vaccinated with pneumococcal vaccine, like say after splenectomy, so you have to give the vaccines before and after as well, still you have to treat them with penicillin prophylaxis. Why is that? That is because all the serotypes of pneumococci are not covered by these vaccines, so you have to continue the prophylaxis, and the duration varies. Most will continue it until the child is 5 years old, and if there's immune problem, you might have to continue it longer, and sometimes up to lifelong. And ongoing vaccine development is needed to cover new strains. For example, so initial pneumococcal vaccine to be introduced was PCV was 7-valent vaccine, and after introduction they found out that certain other strains which were not prominent at that time started causing problems, causing chest infections, like for example serotype 19A. So then later on they covered those strains also. It is covered in PCV 13. But when you compare PCV 13 with PCV 10, the additional advantage of PCV 13 is limited, like it is around, it give additional 4 to 6% protection only. when you compare TCV 10 versus TCV 13. So we'll move on to Varicella Zoster viral infection. Epidemiology of varicella has been changed dramatically since the introduction of varicella vaccine in USA. Children are the most commonly affected by varicella, and adults and infants are likely to have severe disease and complications. Taking a varicella vaccine, overall incidence came down by and number and size of outbreaks also came down, and the complications from varicella also declined dramatically. So what about varicella zoster viral infection in Sri Lanka? So usually in temperate climates, majority of the children are immune to chickenpox by the age of 5 years. But Sri Lanka is remarkably different in this regard, because our statistics show that only 76% of our population had chickenpox by 60 years of age, and only 36% of women of childbearing age, actually 36% of women of childbearing age were not immune to chickenpox. So we'll talk about this infections in the next few slides. Another study was done among medical undergraduates, and it showed that this chickenpox infection causes severe disruption to their life. So they recommend varicella zoster viral immunization for these undergraduates. So what are the clinical features of chickenpox? Primary varicella infection in children is generally a mild disease, and the incidence of infection, hospitalizations, and mortality have all declined since the introduction of varicella vaccine, and it is highly contagious, and the secondary household attack rates are more than 90%. That means if one person in the family got the chickenpox, there's high risk of rest of the family to acquire the disease if they were not exposed earlier. And few things about the rash. So chickenpox rash starts in the trunk and then it spreads to the limbs, as opposed to smallpox where it is spread in the opposite direction. And in chickenpox, at any one point, you can see these blisters of varying ages and varying sizes. So how does it transmit? So transmission occurs in susceptible hosts via contact with nasopharyngeal secretions, and also by direct contact with the vesical fluid. And the incubation period is around 2 weeks, and initially there will be prodrome of fever, malaise, pharyngitis, followed by development of this typical rash. And it remains to be contagious from 24 to 48 hours before the rash, up to 3 to 7 days after the onset of rash, or in other words, until the vesicles are clustered. So complications, what are the complications of chickenpox? In children, it is mostly superinfection of these skin lesions, but pneumonia is commonly seen in older age group. And disseminated varicella is seen in children with underlying malignancy and who are following or treatments, and HIV infection, and children who have undergone organ transplantation. So the complications you have listed there, they include bacterial infection by standard pneumonia, especially in the old age group, elderly, and it can also cause encephalitis and cerebral ataxia. So sometimes cerebral ataxia quite commonly we see actually in the in ward setting, and so these children come with days to weeks after the settling of the chickenpox. They come unsteady gait, and then we can do this blood tests and CSF studies to confirm diagnosis. And usually it's a self-limiting disease, and they will recover during a short period of time. And it can also cause hepatitis and pancreatitis, also bleeding disorders and thrombocytopenia. You call it hemorrhagic chickenpox, and there can be renal involvement, and then arthritis, cardiac involvement, and congenital infection, and also perinatal infection. And there's another entity called progressive varicella, where these new lesions continue to appear for weeks, and the mortality of that condition is high. And this picture over there shows what you call cicatricial skin scarring due to congenital rubella syndrome. Sorry, I beg your pardon, congenital varicella syndrome. So varicella zoster infection in newborn, it can be due to the vertical transmission from the mother, or it can be acquired after birth. And congenital varicella syndrome occurs if the mother is infected during the 8 to 20 weeks of gestation. So the first picture over there shows the typical rash, and second picture shows this typical scarring with limb hypoplasia. So clinical manifestations of this congenital varicella syndrome include cicatricial skin scarring and ocular defects including cataract, chorioretinitis, and so on, and also limb hypoplasia, bone and muscle hypoplasia, and CNS involvement, renal and autonomic nervous system involvement. So neonatal varicella mortality is quite high. Neonates born to mothers with viral infection, or who were exposed within first 2 weeks are at increased risk. And the risk of mortality is very high if the mother develops the symptoms 5 days before the delivery and 2 days after delivery. And why this is so? That is because there's no sufficient time for the maternal antibodies to transfer to the child. And clinical manifestations can vary from mild illness to disseminated disease. And diagnosis of neonatal varicella zoster viral infection can be made clinically. And if it is there, uncertainty is there, you can detect the virus by PCR. And our setting, sometimes we do what you call Sank smear to look for multinucleated giant cells, and it is also seen with herpes lesions. And mothers with active disease, or those who are seronegative with a history of exposure 6 to 21 days before admission, should be isolated. And newborn should be isolated from the mother until she is no longer infected. And any infant who develops varicella must be isolated from other infants. And so for neonates with significant exposure, with varicella zoster viral infection, you have to give them varicella zoster immunoglobulin. If they develop if the mother develop this rash, as I mentioned earlier, within 5 days of delivery or 2 days after delivery, then you have to give the baby varicella zoster immunoglobulin. Or if they are premature also, depending on the mother's immune status, you have to give varicella zoster immunoglobulin. So if varicella zoster immunoglobulin is not available, other option is you can give this normal IVIG. But the problem with normal IVIG is the amount of varicella zoster immunoglobulin in that preparation can vary from batch to batch. Then you have to start them on IV acyclovir as well. So, born with severe zoster viral infection, you have to give antiviral. High risk of morbidity and mortality without the treatment. And usually we give treatment for 10 days, IV acyclovir, and you can continue breastfeeding these children. So, treatment of chickenpox. So many require supportive care like this, supportive management of fever, and this rash is very pruritic, so you have to give symptomatic management. And usually the healthy children who are less than 12 years, they advise not to give antiviral therapy. But antiviral therapy can be given in certain groups, for example, unvaccinated children who are more than 13 years old, and children with chronic cutaneous or pulmonary disorders, and chronic salicylates. As you know, the salicylates can cause Reye syndrome, and hepatic involvement is there, and chickenpox also can cause hepatitis. So, the competent adults, you can give oral antiviral therapy, and severity of symptoms may decrease, and complications will also come down. So, for immunocompromised children, you have to give antiviral treatment. Initially, IV acyclovir, and treatment should be continued for 7 to 10 days. For pregnant women who develop uncomplicated varicella, you can give oral antiviral therapy. So for individuals with complications, again IV antibiotics, IV acyclovir should be given. And few things about vaccination for prevention of chickenpox. So this vaccine is a live attenuated vaccine. So routine immunization with 2 doses of varicella vaccine is at least 90% effective in preventing primary varicella infection, and 99% effective in preventing severe varicella disease. And it has reduced the transmission and also varicella related healthcare utilization. And the vaccine is recommended for children who are more than 12 years old, and also for adolescents and adults without evidence of immunity. So you have to give them 2 doses of varicella. So sometimes following the vaccination, also they can get varicella, milder form of varicella, and it can be contagious sometimes. Especially certain categories like healthcare providers, contacts of immunocompromised hosts, and individuals at high risk of exposure to transmission, like teachers at school and military personnel, and contraindications. So, mentioned, moving on to our last infection, that is rotavirus infection. Acute rotavirus infection is associated with decreased levels of intestinal brush border enzymes, and it will lead to malabsorption of D-xylose and lactose, and as a result, they will develop osmotic diarrhea. So, rotavirus is an important cause of viral diarrhea worldwide, and it accounts for 5 to 10 million deaths per year throughout the world. And typical signs and symptoms include vomiting, non-bloody diarrhea, and fever. Sometimes there can be loose, and in severe cases, there will be dehydration, seizures, and even death can occur. Rotavirus infection in Sri Lanka. Certain studies have shown the incidence of rotavirus infection in Sri Lanka to be in the range of from 24% to 38%. So, most severe disease is seen in malnourished children and children with underlying disease like short bowel syndrome and children with immune deficiency. And rotavirus is also known to cause traveler's diarrhea and outbreaks in colleges and nursing homes. And common lab findings include elevated blood urea due to dehydration and hypochloremic metabolic acidosis. And usually peripheral blood cell count is normal. In immune deficient children, there can be prolonged gastroenteritis and viral shedding. Also, this rotavirus gastroenteritis is observed in association with conditions like neck intussusception, biliary atresia, and CNS involvement. Diagnosis of rotavirus gastroenteritis requires detection of the rotavirus. Commonly used assay is ELI and latex agglutination, and PCR is the most sensitive method. And differential diagnosis include bacterial and other non-infectious causes of diarrhea. So, rotavirus vaccine for infants. So, again, rotavirus is a live attenuated vaccine. There are two oral vaccines available. One is pentavalent vaccine and another one is monovalent vaccine. So, universal immunization is recommended for rotavirus infection, and rotavirus vaccine are highly effective in preventing rotavirus gastroenteritis and associated hospitalization and healthcare utilization. Intussusception is a rare potential adverse effect of oral rotavirus vaccine, and actually it was reported with the first when it was first introduced, and it was discontinued after some time, and then these newer vaccines have shown slightly higher risk than the general population. What are the contraindications for rotavirus vaccine? They are like allergy to vaccine ingredients, severe allergic reactions like anaphylaxis to the previous dose, and immune deficiency because this is a live attenuated vaccine, and certain other primary and secondary immune deficiencies, and history of intussusception, and precautions mentioned there. Basically, conclude my presentation, and thank you. And if you have questions, try to answer that.
Thank you very much, Dr. Vijayavardhana. I think it's a very important, very interesting topic that you presented today. Thank you very much for that. Now,
Thank you,
I would
Chadra.
like to invite our audience to submit your questions. Already we have one question. The first question to you is it recommended a pediatric pneumococcal vaccine for adults? If it is, what is the dose and the dose interval?
No, actually, pneumococcal conjugate vaccine is for less than years of age children, but you can give it up to 5 years. And if you are giving it to adults, you have to go with that 23 valent vaccine. There's a procedure we follow with splenectomy. If you are like planning for splenectomy, you have to, in a child, I'm talking about children, so you have to start immunization with for these encapsulated organisms, that is pneumococci, meningococci, and Hib, at least 2 weeks before the surgery, and then you have to follow it up with additional vaccines later on and with booster doses. Yeah.
Thank you very much for that answer. And okay, this is regarding the varicella vaccine. If somebody is exposed to the disease, I mean, say one child got the disease in the house.
Yeah. So
yeah, the rest of the people exposed, other exposed people to get the vaccination.
Yes,
or
that's yeah, that's a very good question actually. So varicella vaccine actually you can give like as prophylaxis, like after exposure, you can give within 3 to 5 days, and it can protect you from getting the disease. Right. So that is about varicella vaccine prophylaxis. And if any child who is on like nephrotic syndrome children, for example, if they are on steroids, high dose steroids, if they are exposed, and that is an indication to give varicella zoster immunoglobulin. Yeah, so that's a good question actually. So you can use it soon after the exposure. So sooner the better. If you give it within first 3 days, there's a high chance of you not getting the disease. But up to 5 days, you can give it.
I think it's a very important topic because so most of the time the parents and especially when they have daughters at home, they come and ask most of our doctors, the GPs, is it advisable to give this vaccine? So if we give the vaccine, will that prevent the disease? So that kind of questions.
So that is,
do you have any experience like that?
Yeah. Yes, definitely. So mind you, that is after exposure, not after developing the rash. So say this child got exposed to someone with chickenpox, then you have to give the vaccine within first 3 to 5 days. It's a common scenario, and actually, like even so, one study I have mentioned there in my presentation, they did in undergraduates, medical undergraduates, and they recommend that vaccination. Especially, it is important. Like for example, a child. Say, I have I had relatives who developed during their exams, important exams, A-level exam. So that unfortunate child had to wait for another 1 year to sit for the exam. So if that child had been vaccinated, that problem would have prevented. Yeah.
Thank you very much, sir, for that. So,
so I hope you all are typing the new thing you have learned today from my lecture. I have asked at the beginning of my lecture to type down one important thing you have learned from this lecture, one new thing. Yes, Chaturanga.
We have another question from Dr. Vijay Vikrama. Can we give rotavirus vaccine after 6 months?
Actually, rotavirus, usually you have to complete the immunization schedule by 6 months. So this actually I told you that there are two varieties, two vaccines, and this monovalent vaccine you can give either at it's 2 doses. So you can give it at 2 months and 4 months, or 4 months and 6 months. But that other pentavalent vaccine, they recommend, they say you can give it up to 8 months. But it comes with 3 doses. I hope that answers.
Thank you very much. And we have another question from Dr. Khalil. So how important is it to vaccinate a healthy baby only on formula fed since 2 weeks of birth? There any special that if the babies have been formula fed? Is it any
All
limit?
right, so right, so that's also a good question. So some diseases like children will get immunity from the breast milk, actually. But these vaccines you can offer to the, like, if these mothers can afford, any mother or any child, you can recommend if they can afford to get these vaccines, because these vaccines are used in a lot of other countries without any problems, and they have reduced the morbidity and mortality to a large extent. So for children who can, like for the parents who can afford them, offer. But otherwise, formula fed, breastfed, I can't see any other relationship there.
Do you think would there be any sort of connection to rotavirus disease if the child is being formula fed? Could there be an increased chance of them getting the disease?
Formula fed, rotavirus. I don't think so. I have to search on that, so I don't think so.
Okay, we have a question, but I think it's more related to commercial aspects, so I will not read that. I mean, okay, basically the question is about where these vaccines are available. So I think if you ask any pediatrician like you, probably you can direct them to the place where they are available.
Yeah. So yeah. So as you know, like all these vaccines, like it's very important to maintain the cold chain from the time of manufacturing until the child gets receives the vaccine. So it's so you have to go for like place where there are facilities to store, adequate facilities to store these vaccines.
Yeah, and also yes, these vaccines are available in Sri Lanka. So I think that's another
Of
part of
course,
that question.
actually, so
And
yeah, so pneumococcal vaccine, 10-valent vaccine is available at present. Chickenpox vaccine is available, and rotavirus, both vaccines are available, monovalent and pentavalent ones are available. Pneumococcal 13-valent one is not available at the moment, and they are not using anymore that pneumococcal 7-valent vaccine. As I mentioned earlier, the benefit of 13-valent vaccine over 10-valent vaccine is only the benefit is around 4 to 6% benefit. So both are equally effective, you can say, almost equally effective.
I think, as you said, also not to forget that to look for a reliable place where they properly maintain the cold chain as well.
Definitely.
All right. As per your request, I think there's one Dr. Vijay Surya. He has mentioned that I learned about importance of pneumococcal vaccine.
Well, very
Thank
good.
you for that. It is very useful. Okay. I think we are on time. So still, if you have any questions, you can forward us. Even after this webinar, if you have any questions, I encourage you to forward those questions to us or direct to Dr. Vijayawardhan if you have contacts, or if you can reach out to him, or else you can simply uh, put forward those questions to us, which we will get the answers from Dr. Vijayawardhan. So uh, just before we conclude, uh, I would like to thank Dr. Mahesh Vijayawardhan, who has kindly accepted our invitation and doing a great presentation today. And definitely would have cost a lot of your valuable time. Uh, and I really enjoyed the session and learned a lot of things. And I believe it has helped our doctors who have joined with us today as well. So thank you very much, sir.
Thank you
And
very much, Chatura.
also, I must thank all our attendees today for this webinar. Without your presence, this webinar wouldn't have been a reality. So, thank you very much, everyone, for joining with us this afternoon for this webinar. So, we will be meeting you. We hope to meet you again with one other topic in near future. So thank you very much and have a pleasant evening. Goodbye.
Thank you, Chatura.